Let's start with the presentation of Yakubu. So I'm so happy to have you here because you're a really experienced course director with much larger and better courses in London. You can learn a lot of him, and he will motivate us now why we should do an EMG.
Thank you very much for the kind invitation, and I'm really honored to be at this course once again. And it's brilliant to see some of the places here because we do meet a lot in different places. And I'm so glad that you guys are able to attend this meeting. And there are similar meetings that you need to look at as well, the one in Rouen, the laryngeal innovation, and in the London as well. I think if you have this triad of meetings, you'll find that your knowledge in neurolaryngology will be hugely improved, and you find that there are lots of things you can do. The idea for my talk today really is to show you what I do in my clinic, so that at least you know that when you do laryngeal electromyography, it's not just a piece of machine that you have there, because the problems we have these days, people say, well, what can you do with it? I've had some speakers say to me that, well, I do this without an EMG. But again, like anything, if you look many years ago, when we used to use endoscopic sinus surgery, there was no stack system. And people say, oh, I can do cold work, I'll do everything. I don't need stack system. But now people will laugh if you do any phase without a stack system. So when new things comes, we need to embrace it. And we need to learn, and then we need to develop it. If we don't do that, if we shy away from it, we're never going to learn about it. And I think some of the companies here say, like the Moderator, when they start things like cochlear implant, laryngeal pacing, there will be disappointment to start with. So anything good, you have to face some disappointment before you carry on. So without further ado, I'm hoping that I'm going to cover these areas for you. There's the diagnosis, the prognosis, and then how we use the EMG for a Botox injection. You're going to hear a lot of repetition. Repetition is good. When you hear newscaster broadcasting important news, they repeat it over the course of the day. So there's something, when you're learning something from the study, it's good to hear it over and over. And the more you hear something, the more it sticks to your head. Otherwise, you may think that you understand it, but actually when you go, so what did he say kind of thing? So we're going to have some few repetitions, and then we're going to have hands-on tomorrow. Feel free to ask us questions, talk to us during the meetings and outside the meetings. You need to share your contacts as well. You can text us or email us or anytime you want if you want any advice. So nerve injury, this is all about nerve injury, isn't it? And there are so many things that can cause nerve injury, as we know. Some of them would be us that cause the problem. There's the surgeons through what we do, like the thyroid surgery, etc. Post-intubation is slightly controversial regarding nerve injury. I would rather say maybe a vocal cord injury as opposed to nerve injury. Up until the COVID period, I used to think that intubation is one of the causes of vocal cord paralysis. But actually, in 99% of the cases, if a patient comes to you with immobile vocal cords after intubation, until proven otherwise, it's going to be calcoarytenosis ankylosis or posterior glottic stenosis. And this is why the EMG is very useful, because it will help you distinguish this. And then at the same time, you can take the patient back to theater and then look. Neck trauma, idiopathic, inflammatory, neurological, the whole list goes on. Some colleagues may say, well, I'll just have a look at it, and then I'll be able to tell you if there's paralysis or not. And when you ask them, how can you tell? They'll say, well, if there's atrophy, then it must be paralysis. Yes and no, because sometimes, not all the time that you're going to have atrophy, because if you have some kinesia, or if you have some remaining nerve supply to the muscle, there will be some muscle tone, but it's not going to be moving the vocal cord. Common one is the idiopathic vocal cord paralysis. And sometimes even following trauma or surgery, there may be some collateral nerve supply that is not sufficient to move the vocal cord, to keep the tone in the vocal cord. Take, for instance, this first video is a patient with idiopathic left vocal cord palsy. It's one of the patients that I did laryngeal innovation on. So the vocal cord bulk is there. It's not completely. And then the next patient is metastatic lung cancer. Old lady with atrophy there in the vocal cord. So yeah, you have a rough idea that this is some atrophy there. But there are cases following intubation whereby the vocal cord is not mobile. In the clinic, it's very difficult to see calcoarytenoid ankylosis. It may look exactly like vocal cord paralysis. There are cases, of course, that you'll be able to see posterior glottic stenosis, but sometimes you may have for instance, in this case, the vocal cord is not mobile. not different from the first one I showed you, paralysis. But when I took the patient to theater and had a look, and behold, there was a scar. You can see a scar over there. So let's see if I can get the mouse working. So you can see there's a scar over there. And in this case, if you divide the scar alone, it may not be sufficient. You may need to inject steroids to prevent the scar reoccurring. But even that, sometimes it may still come back. So sometimes I put a balloon to dilate the area. Despite that, there are cases that I have to go on revision. In some cases, I have to do what we call lateralization suture to pull the vocal cords apart for it to stay laterally. So there are so many things that goes on when you see these patients with immobile vocal cords. So for patients that you're thinking about selective re-innovation, I don't know if anyone is going to do one next week. Anyone from here going to do one? Yeah, so you're going to learn that next week. For selective re-innovation is very, very technical demanding. So first of all, you have to select the patients properly. How do you select the patients? You have to be sure that it's not ankylosis, because if there is ankylosis, when you do your renovation, it's not going to work. How do you distinguish the two main things you need to do? You have to examine on the GA, you need to palpate the arytenoids, and also you have to do EMG. So these are two cases of mine that I was contemplating selective re-innovation. And the first one you can see over here. So I did the EMG from the PCA, and it shows there's paralysis on both sides. And when I checked the arytenoids, it was mobile. But meanwhile, the second case, the carpal-arytenoid joint was not mobile. And then the EMG was showing full signals there. So if you don't do that, like people that say, oh, you don't need EMG for this, you don't need that. If you go and cut the nerve for the one with the posterior clotic stenosis, of course, you're not going to get any improvement at all. So take that on board. But not only that, there are patients whereby they present with hoarseness, and when you look at the vocal cord, there may be some subtle paresis or complete paresis, and any of these conditions can present. I've had a couple of patients that presented to me with hoarseness of the voice, slight sluggish cords. One of them turns out to be multiple sclerosis, another one motor neuron disease. So this one is a famous one in the UK. The
Wheelie community gathered together at Headingley Stadium in honour of Leeds Rhinos legend Rob Burrow, who's been diagnosed with motor neuron disease. Burrow held back tears as he took to the field in front of more than 20,000 people at a special pre-season friendly featuring current and former players of the Rhinos and Bradford Bulls.
I've been looking to win
some somebody like that, when they come to you, the EMG may give you a pointer towards whether this is a motor neuron disease, not necessarily on the vocal cord. The neurophysiologist will tell you that if they do the muscle testing, which we're going to hear a lot later, you have an idea whether it is that. There are patients that will come to you with functional dysphonia, and you may think they've got vocal cord paralysis or paresis. And also in such cases, the EMG may point you towards the right direction as well. This is a patient of mine with functional dysphonia, which I did a biovisual feedback. Now, some people may describe this as paresis or functional dysphonia, but at the end of the day, with just a visual biofeedback therapy, the patient got
1, 2, 3, 4, 5.
And quickly, I'm going to go through spasmodic dysphonia. I know Berit is going to go into the details of doing the injection. Spasmodic dysphonia can affect any age, but usually it's diagnosed late because physicians take time to make the diagnosis. The adult is the commonest, and the patient feels that someone is strangling them.
You count 1 to 5 for me, please.
Almost the patient feels like they're loading their voice on a slow computer. This is something that the patient doesn't like most about this condition. It's not just the sound of it, it's the feel, how they feel like someone is just sitting on their neck. And then some patients may have a combination of tremor with spasmodic dysphonia, and in some cases, do the abductor, which is the most commonest. So EMG, how does it help us? We know that the nerve supply to the intrinsic muscles of the vocal cords comes from two different sources. So the superior laryngeal nerve, which is the sole supply for the cricothyroid muscle, and then we'll have the recurrent laryngeal nerve as well. So depending on the level of the injury, if it is a high injury or it is a low injury, your nerve, the EMG will give you an idea. Take, for instance, if it is the current laryngeal nerve, when you do the EMG, the PCA and then the TA, because it's supplied by the current laryngeal nerve, there will be abnormality. But the tension muscles, the cricothyroids, will be normal because it's a superior laryngeal nerve. And again, if you have, say, somebody has thyroid surgery and they cut the superior laryngeal nerve during time, the superior pole, the CT will be abnormal, but the PCT and the TA will be normal. The vagal, if you damage it at higher up at the skull base, again, you have abnormality for both the PCA and then the CT. Meanwhile, if it is a fixation or posterior glottic stenosis, you'll have normal signals in all the nerve supplies there. The question is, when do you do the test in the EMG? Again, you're going to hear a lot on this. I'm just going to go through very quickly with this slide that I borrowed from my friend here, Gerhard. Whereby if you do that within the first 2 weeks, you're not going to see any changes. It will show us it's normal, even though the vocal cord is not moving, but the signals on the machine is going to be normal. And again, over time, you're going to start to have synkinases whereby the nerve supply to the PCA will go into the TA, and from the TA will go to the PCA. So when the patient trying to sniff, you have different muscles moving. We're going to go into the details of that. So it's just like a highlight on the TA. When the patient is sniffing, you can see signals there, but actually when the patient is sniffing, the TA shouldn't show any signals. So if you have the needle in the TA and you ask the patient to sniff, there shouldn't be movement. And if you have the needle in the PCA, and when you ask the patient for, let's say, E, you shouldn't have signals there, but it will show signals in the machine there. So this is what this is telling us all. So what surgery might we offer? There are lots we can offer these patients. The commonest one is an injection laryngoplasty, which we do at any time anyway, whether the EMG is going to show recovery or not, because we have temporary injection materials. But there are permanent treatment that we offer, like thyroplasty. Typically, I wait 6 months after injury before I offer the thyroplasty. The re-innovation, I wait for 12 months before doing that. The laryngeal pacing, we're going to hear from the experts later. And what sort of signals do you get? For an ENT surgeon, I just look at it and see how many zigzags do you have on the screen, but I'm lucky to have a neurophysiologist who look at it with the microscope and say, okay, this is going to show poor prognosis, 1 motor units, 3 motor units, 3.5 motor units. Hopefully you're going to learn today, but we don't have anyone with vocal paralysis today here, so we may not see that, but in the presentation we will see. So it's not difficult to work out what's normal for me if I say it there. So there's lots of zigzags there, but for the paralysis, you see that. But sometimes if you're not in the muscle, you may not see anything at all. So I work very closely with my neurophysiologist, because if the needle is in any type of muscle, you're going to get some signal. So you have to be sure and certain that you're in the right muscle. So again, we're going to try that. If anybody wants to try it on their neck today, feel free. Give us your beautiful neck. We're going to start it with needle today, if you like. So once we make the diagnosis, and if my neurophysiologist said to me, this pathologic spontaneous activities is unlikely to recover, then I'll have a chat with the patient, give them the options, and say, do you want the thyroplasty or the re-innovation, and tell the pros and cons. And majority of the patient will provide the re-innovation because they don't like the idea of having an implant. Some people are questioning whether the re-innovation does work. It does work, and I'm going to show you from my cases here. And because not many people are doing it, they're still hesitant in doctors to do that. But really, it's a very nice operation. You don't leave any implant. Once you connect the nerve together, you don't need to do anything. And the result, it keeps continuing to get better. With thyroplasty, over time, the patient may find that the voice has dipped down again because of atrophy in that. So it's not a very complex operation. For those who are attending the meeting next week, you're going to see some of this talk as well. But essentially, you identify the ansa cervicalis, and then you cut it and you identify the current laryngeal nerve, and you stick it together, and you use a 9-0 proline, a couple of stitches. You're not trying to anastomose it because it's not a vessel. You just want to bring the axons close together. When you bring the axons, they will attract each other, and then they will just go and it will grow. It takes about 6 months for it to start improving, and then by 12 months, the patient's voice is very good. So again, this is what you do. You try to stitch in the perineum. You don't want to crush the axons that you want to recover. So I'm just going to play a short clip of video of 2 minutes on the procedure. This is highly sort of edit, and you can just sit down and relax and enjoy. So this is the ansa cervicalis. You can see that. This is the internal jugular vein. You have to do this under high magnification. This is going to that. Like you do there. And this is the recurrent laryngeal nerve. And then you cut it. Use a 9/0 rolling. And then after that, you put a piece of fat there just to reinforce it, and it has some growth factors in it as well. And the fibrin glue just to keep it from stretching away and separating. And this is the patient, the pre-op and then the post-op.
5, 2, 3, 4.
And this is 10 months post-op. So it doesn't make the vocal cord move, but it restores tone so that the vocal cord comes in the median position, which is what we're trying to achieve with thyroplasty injection. So, and this is another patient that has a neck stab wound.
1, 2, 3, 4, 5.
See how the vocal cord is bowed and it's not moving, with enough saliva there. And this is the EMG on this patient. I don't know if you can see anything there. So you can see you compare the normal and then the abnormal side. And this is the patient 8 months after. You can see how the vocal cord is full. Again, 12 months after, the voice keeps getting better.
3, 4, 5.
So Monday, Tuesday up to Sunday?
Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
And then we did the EMG at 12 months, and it shows that actually there's nerve signal. So this was before, and this is 12 months after. And this is the right vocal cord. So there's rich signals going on there. So in a nutshell, there's a lot you can do with an EMG. Do not shy away from it. It's your friend. You can learn a lot. And your neurophysiologist or neurologist will help you a lot. When you go back to your hospital, find where initially there may be skepticism. So, well, what do you want this for kind of? Because a lot of the neurophysiologists, they do their own EMG, but with the larynx, because it's some way more technical, I don't think they're going to be changing the larynx with the needle. But if you offer your service that you're going to do the EMG yourself, and then they will help you with the technicalities, and I'm sure Jordan, my colleague here, will agree that you will get support on the side beside this in your various hospital. For those of you, I think lots of you will know about our courses as well. Otherwise, thank you very much for listening.